to our DSA monthly health equity series webinars. We love spending time speaking about issues that are concerning the community with our different stakeholders, with people from the systems and the front lines, and students and faculty. So we always hope that these conversations are productive and they help everybody advance and further their understanding of health equity barriers. And let me just start by welcoming you and inviting you to ground our conversation and our reflection today in the recognition and the understanding that we are in Indigenous lands, we're in Treaty 6 territory, we are at the DSA grateful uninvited guests of Treaty 6 territory. And as settlers, we really try to uphold our responsibilities and accountabilities to interrupting colonial harm and redressing the impacts of colonial harm, be good allies, seek allyship with Indigenous sovereignty, be good guests. So I invite you to really enter this space today grounded on that understanding. And I am very pleased about how the session of today came to be, because it really came from our students mostly, and from us learning from the work, and I mean having an ongoing relationship with the physicians that work at the refugee health clinic that we're going to learn about. So you're going to hear from people that are doing frontline and advocacy work, and we of course want to remind you that the DSA exists because there is a mandate for medical education organizations to be able to address the priority health concerns of the community where they're situated, and that they need to collaborate with community stakeholders to understand better and address and do advocacy with the system so that those inequities are addressed. And we also have a mandate to form physicians and educate students who understand the responsibility that comes with being a physician, right? What are the social responsibilities and accountabilities that physicians have in Canada towards being leaders and communicators and advocates for the communities? So just with this brief introduction, maybe I should say I am Dr. Manuela Valle Castro. I am a settler from Chile and from South America, and I am the director of the Division of Social Accountability. We are planning to have ongoing work with both the students and the physicians that work at the clinic, and we invite you to get involved with the work that they do as well. At the end, we're also going to be sharing ways in which you can contribute with donations to the work that they're doing, because they are interested in raising funds for their work, sustaining their work too, because as we're going to learn, one of the barriers is the lack of support. So with that, I'm going to invite, I think, have those issues with slides been sorted out with presentation?
I'm actually not able to open them. So were you guys able to share your screen at all? No?
So I wonder if maybe we should let the student group go first while we figure out that issue. Would that be okay with you guys? With Jacelyn and Karen? Dr. Leis and Dr. Hanson? Do you prefer that the students go first, or how do you want to proceed? Yes? All right. So I'm going to invite then Adrian and Rosario, who have brought to our attention a campaign that they're going to be talking about. and they are absolutely fantastic advocates, aside from being brilliant students. So we're very honored and grateful to have them here. Thank you. Rosy,
Hi,
dale.
thanks, Dr. Maya Castro. My name is Rosario. I'm one of the third-year medical students. I'm working with Adrian, who's also here today. We're part of the Immigrant and Refugee Health Club, and recently we've been advocating for Saskatchewan to be a sanctuary city. And this is just kind of an overview of it's a very simple overview that we plan to like educate organizations with, but I'll break it down further because I know you guys know a lot about immigrant and refugee health issues, and that's why you're here. Just kind of our advocacy plan, and then Adrian will talk more about the steps we're already taking. So what is a sanctuary city? So you may have heard it's kind of a worldwide movement in response to national and international treatment of migrants. So I'll define migrants in a bit. What our vision is with this is a Saskatchewan being a sanctuary that creates policy to protect non-status immigrants from deportation, but prohibiting the use of local resources and budgets for cooperation with federal immigration law. We also envision this policy to improve access to basic services and to promote and protect the rights and health of non-status immigrants. So we're all in agreement that that we all deserve rights. So who are non-status immigrants, also known as undocumented immigrants in the United States? Persons who entered the country and remained in Canada without permission of the federal government. Becoming undocumented is very complicated. There's a flawed immigration system. I myself was undocumented for 15 years in the United States. And I can tell you it's very complicated, and breaking it down in Canada is just as complicated. But I'll give you some examples of who this includes. So it can be visitors to Canada who come here for, let's stick with health. So health reasons, they come and visit a family member, but they overstay their permit. So they're only allowed to visit like 3 months, and they overstay that because they're taking care of a family member, for example. Or temporary workers with expired work permits. This is very, very common, especially in COVID times, because applying to extend your permit is taking so long that people are overstaying and have expired permits, but they're in the process of like trying to renew them. So things like that are complicated. A lot of our international students at the University of Saskatchewan have student visas, are master students, and their visas expired. Or they can be in the process of trying to renew them, but right now they're kind of in limbo, or they just stay because they enjoy their life here. And then other visa holders, there's a lot of different visa statuses that could expire. And then asylum seekers are people who come in with wanting to have refugee claim, but they're awaiting appeals, and it's quite a process, and people can be stuck in here in this kind of process for a long, long time. So just at the bottom, just kind of what I said. Why do we care? I know everybody in this meeting cares, but we're all human beings, functioning members of society, facing barriers to access healthcare, education, shelter, labor rights, police protections. So things that we need in the everyday. And this is a lot due to fear. So a lot of the research shows that it's due to fear of detection, detention, and deportation. And I can tell you myself that it is true. As healthcare providers, and this is kind of to share with medical students as well, it's our obligation in this country that promises universal and accessible healthcare. So people, regardless of status, aren't immune from illness. We know this COVID it just affects everybody. Diabetes, high blood pressure, things that are common. And a lot of the research also, it's very obvious, but shows us that preventable complications and acutely ill presentations in the emergency department have really high costs to the resources due to just like lack of primary care. And this implies to any patient, right? So a patient with diabetes, with untreated diabetes, and having to go into emergency for a diabetic foot infection, for example. So it's important. So it's really the constant fear and anxiety that people with undocumented status face as well as social exclusion and isolation. And this social exclusion and isolation has been very prominent in COVID, and people are starting to understand it better, how it impacts mental and physical health. But even just not being included in policy, so non-status immigrants aren't included in policy, not in writing, not in the conversations. So that's what we're trying to start here. So what is a sanctuary city? This is our vision. We took this from some of the like Toronto, Montreal, and some of the cities in Canada have done this and have a good layout. So we have three main goals. One is allowing individuals to access most city services regardless of immigration status, or to improve access. And this is to things like education, shelter, protection from police, and then healthcare, of course. Two, we want to train community organizations, police, health services, not to ask for information about immigration status. And this goes with the next point, which is prohibiting the disclosure of any information. So in healthcare, sometimes it's important to know a person's immigration status because we want to know how to help them best. But we want to prohibit that information from going to the federal authorities. So this is just a first step. And these are the names of some of the other cities have called this policy. So access without fear, don't ask, don't tell. And we want to give migrants the peace of mind to access services. These are some examples: libraries, emergency departments, health services, police services, transportation, food banks. Like, it's quite a wide scope of things that people who are undocumented don't access just because of fear. And it's hard to explain unless you've lived in fear your whole life, but it's very simple things. So some of the challenges, and we recognize that there's a lot of challenges that have happened throughout Canada and why this hasn't been implemented well. And we did a good literature search for that and found some suggestions from the organizations in Toronto, Ottawa, things like that. So the research suggests that the other cities have had very limited results with implementing their policy, just because of resistance from city police. So very much like police not knowing their role and still asking and sharing information with federal authorities. So suggestions include provincial commitment to providing funding and mandate for comprehensive training for staff who provide community services, and then instituting changes in schools, police, and healthcare. So it takes a lot of training, which takes a lot of money. I know that's obvious for everybody, but it's just like one of the suggestions is pushing towards that. Long-term goals are, of course, like transforming traditional core values of these institutions, of universities, of the College of Medicine, police services, and that's what a lot of movements have been working towards, like Black Lives Matter, for example. So movement towards the systemic and policy change has to happen at the provincial and federal level. Our goal right now is obviously to educate the city, but we want to move to provincial is really how we do it, and then the federal level to change immigration policy. So it's just the first step. Again, just kind of redundant work to support individuals facing barriers. And then this is part of participating in an active stand against racism, xenophobia, and creating a welcoming and inclusive city that supports migrant justice issues. Some next steps, Adrian will talk more about these. So we're already here. We've gathered like-minded individuals, that's us, forming a coalition advocating for this, writing a letter to the mayor. This is what Adrian's going to talk about. And then doing public education to raise awareness. Some of this is going to have to come out of volunteer work at first, right? But we know that that's a next step. And then organizing community events like this talk, for example, or just being present in the summer during these community events to raise awareness for both migrants and for people who are advocates. And then, of course, making this an election issue. And then bigger steps beyond this, public education campaign. I won't read all this out, but develop a plan that actually monitors how well this is happening. So there's transparency. So what happened in other cities with the police department doesn't happen here, where police is actually trained and they understand that their role is municipal, and they don't have to share with federal authorities that's not part of their role as police officers. And then just getting that training. So it's just kind of a lack of communication in police departments, really. So figuring out how to do that and hold people accountable. And then provincially funded programs and services to do this as well. And then, of course, we finally call on the federal government to provide pathways to permanent residency. And I can't read that last line because the the Zoom is covering it, but I'm sure you guys can read it. All right, I'll pass it on to Adrian. I'll stop sharing. And we have resources, and we have a whole lit review, and we can answer any questions.
Awesome, thank you so much, Rosie. So yeah, as she mentioned, we are in the process currently of the letter that we are going to be sending to the municipal government of Saskatoon, so specifically the Mayor Charlie Clark. One thing, just for historical context, this topic hasn't really been broached in Saskatoon since 2017, where a city council meeting, we were watching a video of it, and it's basically like 14 seconds of them saying like, oh, there's this motion for a sanctuary city, do we want to consider it? And not like, I think maybe 5 letters had been submitted countering it, and that was enough to get it dismissed right away. So we figured if the letters have the strength to get it dismissed that easily, then a letter might be a good way for us to actually get something moving with this. So that's the route that we've decided to take. We've written a letter to Charlie Clark that we're planning on sending out this coming Monday. It currently has over 80 signatures from our colleagues, and we're going to try to push for, if we could get over 100, that'd be nice before the end of the weekend. But as of now, it's just medical students that have signed on. I think depending on how this first letter goes, we may consider sending another letter, or even sending the same letter and opening it up to general community and other colleges, et cetera, to sign it. But for now, just because of the time constraints that we had, we were just having medical students sign it. And then we also have endorsement from several community organizations, including REACH has signed off on it, Saskatoon Open Door Society, the DSA has signed off on it, as well as the Student Medical Society of Saskatchewan, and then a few other community organizations that aren't directly related to immigrant and refugee health, but are also very much in the business of creating safe and welcome spaces for people. So Out Saskatoon and the YMCA, for example. So another important thing to note is that currently in the prairie provinces, there are no cities that have established themselves as sanctuary cities. Canada actually just has very few in general. It's much more common in the United States, but in Canada here, we have Toronto that has declared itself a sanctuary city and has sort of had a pilot project where Rosie was saying with the evidence they've seen is that without proper training and proper investment in making these procedures standard, the implementation becomes difficult. But then also some other Eastern cities have joined in as well. So Hamilton, London, Montreal, and then on the West Coast, Vancouver has its own sort of sanctuary city policy. But we would like for Saskatoon specifically to take the innovative step of becoming the first prairie province city with that sanctuary city designation. And we're in the hopes that if Saskatoon is willing and ready to start adopting this policy, we'd love to have these conversations in Regina as well. I personally am based in Regina for my schooling, and we would love to have these conversations with both Saskatoon and Regina. Yeah, as I had mentioned before, right now we are only having medical students that have signed off, but Rosie and I have talked, and we would very much like to get the larger community involved in this because we recognize that there are many stakeholders beyond med students. So we'll be submitting the current copy of the letter we have on Monday, but in anticipation of the need for follow-up, we definitely will be releasing that letter and allowing others to sign it because we do feel it's important to include a number of collaborators. And as Rosie did mention, we do have a literature review, and we have sort of like a one-page document summarizing what Rosie went over during her presentation. We'd be happy to distribute those documents to anyone that's interested. And other than that, that's sort of what we have going on right now. As Rosie mentioned, sanctuary cities are very much the first step. And from there, we would like to step up to provincial and federal. But for now, we're focusing on one thing at a time. And I think it would be a huge win if we could get Saskatoon to adopt a policy like this. So hopefully Charlie Clark is willing to meet with us at the very least. And we would love to be able to have a more extended conversation with him about it. I'm not sure if we're meant to be taking questions now or if it's all at the end, but if anybody has questions,
Yeah, I personally have lots of comments and questions for you. I'm like so delighted with the advocacy that you're doing, and we're definitely going to support it and make sure that those materials you're working on make it to other spaces. But yeah, I think that Dr. Leis and Dr. Hanson have solved their technical issues, and they can go ahead with the presentation now, and we'll have our conversation towards the end.
Yeah, that's fine. I think, yeah, we're both kind of technologically challenged, which is unfortunate. But I don't know what the issue was because I use the computer for teaching all the time. In any case, thank you so much for this opportunity to share about the REACH Clinic and its partners, about the work that we and others do there. And thank you so much to the students for this, for your initiative in making Saskatoon a sanctuary city. That's really, really great, incredible, yeah. And we will support you in any way we can. So my name is Karen Leis. I'm a general pediatrician and work at, well, JPCH, but also at the REACH Clinic.
And I'm Jacelyn Hanson. I'm a family doctor, and so I work at REACH as a family physician there, the Westside Community Clinic, and then also at the Lighthouse Shelter.
Perfect. So if you want to pull up our presentation.
So, Erin, are you able to share your screen? Are you host? Oh yeah, it's happening.
It's working. Oh, and maybe just put it on slideshow. Yeah, there you go. Perfect. Victory. Exactly. Okay. So that's great. You can go to the next slide. So we're just going to start with a case that we saw in our pediatric clinic. Of course, it's been de-identified. But Ibrahim was a 15-year-old boy who arrived from Sudan about 3 months ago and was privately sponsored with his family. But they asked us to see him urgently as they had some safety concerns around him. And as he was talking about hurting himself, that he wanted to die, and that he was expressing also some, aggression towards his siblings. And so when we met him, alone the next day, he kind of shared a little bit about his story and what things have been like for him since he came to Canada. And so through an interpreter, he was saying that he was having some sleep troubles, that he was often walking alone at night to avoid being home, that he hated school, that he was feeling on edge all the time, and that when he was not feeling numb, he was just feeling very angry. And he was feeling like very alone. No one was helping him at school or in the new community. And that no one cared about him because he didn't speak English. He said he would never actually kill himself, but he does think about death a lot and has sometimes hit his siblings out of anger. And so, when we're faced with a child or an adolescent who's having difficulties like that, our first question should be, what happened? What happened to you? Not what's wrong with you, right? What happened? And so in discussing with him more, he said that he missed his father a lot, that he was missing in Sudan and didn't accompany the family. He had no idea if he was alive or where he was, that at home he was living with 8 other people, including a brand new baby in the home, and that he felt like his mother was struggling as well, and that she was having trouble adapting and possibly struggling with some of the same symptoms that he was having in terms of symptoms that could represent PTSD. That she couldn't read or write and was trying to work on English, but it was very hard. And Ibrahim himself had never been in school before coming to Canada. He'd never been at a computer, and now he was expected to use one every day. And in Sudan, he had been quite independent, and he just felt like his world had been turned upside down. And he gave us permission to talk to his teachers, and they were surprised to hear that he was struggling so much, because at school he seemed to be doing well. He was kind of quiet, but he seemed to enjoy playing badminton, and he was making progress. So yeah, that was kind of the vignette. So if we go to the next slide, I think, what the story about Ibrahim's struggles and his family kind of outlines the many layers and factors that we have to consider when caring for refugee children, but also refugee patients. They all experience loss, of course, based on the very fact that they've become refugees, and some will have experienced trauma. And, the reasons why they leave in the first place, let it be, war or political persecution, etc., that will result in negative health consequences, and leads them to having more specific health needs compared to their host country counterparts. And even though people need to be relatively healthy to displace from themselves from leaving their country and going to a new one, that journey in itself makes them very vulnerable and to further health issues, whether it be physical or mental health. And once they've reached their place of safety or their new country, of course, it's certainly not over at that point. There are many, many factors that will play into how they integrate into the new society, but often, additional barriers like poverty, language, difficulty accessing care, racism, discrimination can all play a role in kind of leading to poor health outcomes.
Okay, so next slide, please.
Sorry, it's just not advancing here for me.
That's okay. I can kind of start so we just thought we'd kind of outline like who are refugees. So by the UNHCR definition, a refugee is someone who's forced to flee. They're forcefully displaced because of either fear of prosecution for reasons of race, religion, maybe if they belong to a certain or have membership in a certain social group, war, conflict. So I think that's important. I think that sometimes gets lost, that refugees are people or individuals who've been forced to flee. So there was 82.4 million individuals that were forcefully displaced, including, of that, I guess 26.4 million were refugees. That number actually might be a little bit higher now based on Afghanistan and then Ukraine as well. And about 42% of those individuals are actually children. So they make up a large percentage. The top 3 countries right now accepting refugees, or last year, I guess it was Turkey, 3.7 million, Uganda was 1.5 million, and Pakistan was 1.2 million. And like I said, with the conflicts now in Afghanistan and then Ukraine, that might change. Last year, Canada welcomed about 30,000, which was below their target. Their target last year, I think, was 80,000, but because of COVID, which affected the movement of people to Canada, it was much lower. About 50% are actually privately sponsored that come to Canada. So there's government assisted refugees, and then there's also private assisted, and then there's a blended government and private assistance, and then there's also people that are asylum claimants, and so we see all members of those.
We don't have a lot of asylum seekers in Saskatchewan, just not a lot of, I guess the border crossings are less accessible and so on. But I think it was a couple of years ago now, I'm sure you followed in the news that there were increased asylum seekers in Manitoba and Quebec especially, coming from South America.
So next slide, please. So refugees have specific needs. And so that's part of the reason why we think it's really important to have a place like a refugee clinic. So there's often complex experiences of trauma. And like Karen had spoken about, just that people often are either coming from an area of conflict or violence. They're being forced to flee. The journey can often be quite dangerous, and they're often very vulnerable in that journey. And then when they flee, they often, they may have left family behind. Some may have experienced trauma. And so there is definitely this complex experience of trauma that we will see kind of the sequelae of, both like with their mental health and sometimes with their physical health as well. There's multiple physical and mental health needs for refugees when they arrive in the host country, for a variety of reasons. Sometimes their access to medical care has been really limited, either due to, the situation in their home country. Also, when they go to a transition country, often they don't have access to healthcare, education. They're unable to work. So that really affects their health as well. And also, there might be, it's not the majority of what we see, but there's definitely some infectious disease that are related to kind of their country of origin. When they arrive here, there's definitely a lack of familiarity with the healthcare system, and the healthcare system isn't really set up to help like easily navigate. So, there's racism, there's discrimination, there's language barriers. People might not know how to access emerge or urgent care. If they don't have a family doctor, it's really difficult. So, and then language barriers, I think Karen's just going to speak a little bit more to that in the next slide. And then often, there's transportation issues. People are living in poverty, and that really impacts their health as well.
Mm-hmm. Yeah, and I think, we've talked about trauma a couple times now, but to be honest, in the clinic, it's not something that we're asking a detailed history about, of course, as you can imagine. And so sometimes, it will just sometimes comes out on its own, and sometimes, many months or even years later. So we're just aware that about that, but it's not something that we're asking about in great detail.
Yeah. And I find it usually takes years. If someone is at the point where they feel they want to share that part of their journey or their story, it's often at least after the first year. I mean, a patient for me, it was after about 3 years. And so,
yeah, like you were just telling me, he was like, I never told you what happened to me, right? Dr. Hanson, So a word about language barriers, because this is obviously huge. So history taking, in medicine, history is everything, right? If you cannot communicate with the patient, there's no way you can provide good care. That's a motherhood statement, but of course it's actually been studied. And so we know that patients' ability to speak about their health in their own language, and then the medical provider being able to work with an interpreter improves patient outcomes. There's no doubt. And yet, despite that, we know that it's not always used. And medically trained interpreters are certainly the gold standard. We should definitely be avoiding using families, never using children. And so in SHA, all employees have access to a phone interpretation service, which is paid for by SHA, and that's great. But again, not all employees use it or know to use it, which is one issue. And then another issue is that all the healthcare providers working outside of SHA and fee-for-service clinics would not have access to this, and so would be even less likely to use an interpretation service. We're lucky with the settlement agencies that we work with. They provide an in-person interpreter for every new patient assessment, which is just invaluable. You can go to the next slide. Oh, no, I wanted to tell you, I wanted to tell you one quick note about that. This was actually you can say it because it was your patient.
So a number of years ago, I had a patient who was admitted to the hospital, and they unfortunately had a meningioma, so a brain tumor, and they had a surgical resection done in the hospital, and this patient did not speak English. And so I actually had went to see the patient about 10 days after their operation, and she was going to get discharged And so when I seen her, of course, I pulled out my cell phone and I got my phone translation on. Like I used the phone translator on my cell phone. And I realized at that moment, she didn't know who I was. And I'd known this patient for a number of years, didn't know that like their children. So, when I approached the nursing staff and I said, like, has anybody used translation with her? And here she had been there 10 days post-op, about to be discharged, and nobody had used translation services with her. And so they just assumed that she was doing fine and we're about to send her home. So, I mean, that's an extreme example, but we see it, unfortunately, very often.
Yeah, powerful story.
Okay, so for the next
slide, we'll just talk a little bit more about Reach Clinic.
Is. So we're a community-based clinic. We're interdisciplinary, and we really tried to provide a culturally safe place and to provide care to Saskatoon's refugee population. It was originally started in 2016 as a weekend and evening clinic with the kind of wave of Syrian refugees that came at that time. And then after that, there was really no clinic for, I don't know if it was a year or a number of months. And then in 2017, Reach was established. And we're based out of the Saskatoon Community Clinic, and we work in partnership with many organizations. So if you just want to go to the next slide. So this is who we collaborate with. And really, we could not do what we do without everyone involved, especially, the community clinic, of course, but then also the settlement agencies. They play a huge role, and we have a very good working relationship with them. So like I said, we're based out of the Saskatoon Community Clinic, and then we do have a relationship with the Saskatoon Health Authority through public health with immunizations, and then the two settlement agencies, Global Gathering Place and Open Door Society. And then we also work with TB control as well. And then, the University of Saskatchewan and the College of Medicine. Next slide, please.
So when we were talking about, it's not like we started the first, clinic with dedicated refugee care in Canada or anything. There are many other models, but the idea is that it's a centralized, kind of low barrier, specialized, dedicated health services. So at the clinic, at the Saskatoon Community Clinic, what's wonderful is that everything is on site. So we can see our patients there, and then they can go downstairs to the lab and the pharmacy, and we work closely with them. The pharmacy is very well experienced and knowledgeable about the interim federal health plan, and helps us often with choosing medications that are covered, etc. We use interpreters consistently. I mentioned that with new patients, we have the in-person, and then we use the phone interpretation services for all other patients. We work closely with the settlement agencies, and so they help kind of communicate with patients. There's actually a special program within Global Gathering Place that helps accompany vulnerable refugees with health problems. So they almost have kind of it's not a mentor, but it's a health, yes, thank you, health navigator, and who accompanies them to appointments, coordinates their care, and so on, because that can be very overwhelming, of course. And really, we're looking to improve their health outcomes and ultimately, play a small role in hopefully, improving their integration into Canada. Next slide. So you can kind of see how, a fee-for-service medical model may struggle to provide that type of care. So currently we have 3 family doctors and 2 pediatricians, and we have family medicine 4 days a week.
4 days, not full days, but 4 days a week.
4 days of the week, and then peds once or twice a week. And we try to see patients within 6 weeks of arrival. Sometimes that takes a little longer. For example, in the fall, we had 200 Afghan refugees arrive, and so it took us about 4 months to get through those with some extra clinics and so on. And then we follow them in the clinic for 1 year, and then usually transition to them to a family physician in the community, possibly someone who speaks the same language as them, if that's possible. We didn't transition anyone during COVID because it just was too complicated and everyone was strapped. But on average, we have about 350 new arrivals per year. But of course, that can change with whatever's going on worldwide. And so most of them currently are coming from Syria and the Middle East, Eritrea and Ethiopia, Sudan and Somalia, and just a few from Colombia, Burma. So next slide.
So how do we know a clinic like ours, like REACH works? So decreased referrals. So with our collaboration with TB Control, we do a lot of our own latent TB treatment. And so with that, we did a study actually looking at our latent TB population and found that our completion rates were quite high. They were over 90%, which is, I think, much higher than the rates that are traditionally coded for latent TB. And I think it's partially just because of our clinic. It's a familiar place. We know the patients well, and we can really kind of wrap around care. And so that's, and then we do, I think, we believe that we refer much less to specialists just because we are a little bit more, we have training for, certain things. And so like tropical diseases. And then we do have dedicated mental health services through Global Gathering Place, which has been a real helpful thing to have. They did a study after the Syrian surge, and it did demonstrate that there was decreased ER and acute care visits. And then as well, we had a master's student do an evaluation in 2019 and 2020. And just from that, it was questionnaires and then interviews as well. And the main kind of themes that came out of that was that the time that we were able to spend with patients was really appreciated, that we consistently used interpreters.
I thought I was frozen. Did we lose Dr. Hanson and Leis there?
I think we lost them.
Yeah, it looks like they're frozen.
Okay.
They don't look frozen, but they are frozen.
I'll just email them and let them know to re-sign in.
Well, and in the meantime.
Oh, you guys are frozen.
Oh no,
there you go.
Are we
There you are.
Oh my goodness.
Okay.
Okay, you can go to the next slide.
You can go to the next slide.
Sorry, I don't know. We must just have a glitchy system today because
to
it's not letting me go to the next slide. But
we can
this happened.
we can just talk, yeah. So
it probably will in a minute.
We believe like having a dedicated refugee health clinic really helps improve health outcomes. Well, we know that it's been well studied that if you have a dedicated kind of culturally safe clinic, the health outcomes will improve. And by improving health outcomes, then you could improve like integration into your host community. And then also we believe, well, by providing kind of a stable environment with trauma-informed care, you can really, you may decrease some of the sequelae of previous trauma. So it's all, we believe, really important to have this clinic for when patients or when individuals arrive.
That's right. Yeah. Okay, next slide if possible, but if not, that's okay. So, it's our last slide basically. So we're at the end, it's fine. So our hopes for the future really, I mean, we've been working very hard with Lisa in particular, who's been an amazing supporter and advocate of the clinic. Just expansion of increased physician time and coverage and increased services. And so we've actually had a little bit of success with that, which is great. And so we'd like to just continue building on that. We want to, and that includes, building in sustainable funding sources. We have requested permanent funding from the government on multiple occasions and have not been successful. And then another piece that, is really important is provincial coverage of phone interpretation services. And in fact, Jacelyn submitted a motion to be presented at the Saskatchewan Medical Association AGM, which is happening next week. So that would be great if it was accepted and would provide some impetus to getting this done and moving that project forward. So thank you so much for your time and attention. And we're very happy to to be here and work with all of you.
Thank you.
Karen and Jacelyn and Adrian and Rosie. We're really happy and grateful that you have been able to share with us. And I just had some like comments and maybe we'll open it for some questions from people. But I thought it was really great that you did mention how the role of kind of like global inequities and how Canada does have a responsibility to provide health for refugees, because we do participate in some of those global inequities. So in other words, we do have a role in pushing some people out of their countries, in particular, if we think of the role of mining and extraction in Central America and South America. And those are the ones that I'm familiar, but you know, like the government is not innocent in that sense, that we do have, and also our immigration system is very flawed in many ways, right? Like we, as an immigrant myself, I came here with a lot of privilege, right? And because you are filtered, there's a health filter to come here as an immigrant, right? You have to prove your health, that you're not going to be a burden to the system. But still, I found myself twice being unable to take a mat leave because I would lose my immigration status. Right? So there were things that even as a very privileged immigrant, I experienced. So I like that you place this problem within the context of there's global inequities and things like war and humanitarian situations that we have to respond to, because we do benefit and have a lot of wealth because of also our role in extracting wealth from other countries. And in particular, because some of those undocumented people, right, are it's entangled with also our temporary workers policies, right? We didn't even get to talk about, for example, the aberration that it's our living caregiver program system that has been that has enabled a lot of exploitation and barriers and abuse for women coming from the Philippines to be living caregivers. And the same with our seasonal farm workers that come from Central and South America, right? Who, when COVID exploded, found themselves without any kind of like protection or guarantee and just completely unprotected when they come here to contribute to our economy, right? And like feed us and everything. So I think that it's important to remember that this is not kind of like a role for like charity or nonprofits. This is a role that should be addressed with public policy from the government, right, in a sustained and responsible manner. But yeah, I see that Adrian already has a hand up, and we'll just go take it as a conversation from here.
Awesome. Yeah, thank you, Dr. Vallecastro. I do agree that we do have a responsibility just as a community of humans and individuals to respond to these very humanitarian crises. One thing I forgot to mention earlier on that I think is really important that is included in this, and just to note that we've taken consideration of it, is while we are extremely concerned with responding to the international crises that lead to migrants coming to Canada, we also are very conscious that we have our own systemic inequities here in Canada with our Indigenous peoples. And given that sanctuary cities are inherently based upon the concept of hospitality and welcoming people in, it creates this strange space for us where, as settlers, do we really have any right to practice hospitality in land that isn't ours? So that's something that we made sure that this letter, we sent it off to the Saskatoon Tribal Council, Federation of Sovereign Indigenous Nations, Métis Nation, Saskatchewan, and then Comfy as well. We haven't yet heard back from them. I know in my previous attempts to get in touch with them, they're sometimes pretty busy and it's tough to track them down, but we'll be continuing to try to consult with them as best as we can with the letter. And more importantly, if this does lead to actually implementing policy, we do want to make sure that these organizations are heavily involved, because this is their land and we want to ensure that they're actually, well, I mean, for one, on the same page as us, and also that they're informing the process of how we welcome people into this land. So yeah, I just wanted to say that before any questions.
What a great point of clarification and reflection as well. I'm curious if there's comments or questions between panelists, or if the people in our audience have any comments or questions, maybe how to engage further, how to support some of this advocacy and frontline campaigns. You can also type if you're feeling super shy. Oh.
This actually, this raises a good point. We actually did do this as well with one of the Indigenous student societies within the College of Medicine specifically. We haven't gone more broadly to the rest of the university because so far we have just released this letter within the College of Medicine, but we have Wichitawin is the, or the Indigenous Rural and Remote Health Group, as they're otherwise known, is a group within the college that Rosie has sent the letter to, and their president has passed it on to the rest of the group, as well as the rest of the Indigenous students within the college. And so we're still awaiting direct feedback from them, but we have been consulting with them and yeah, are very interested in what they have to contribute.
I also was wanted to really emphasize what you were talking about, the consequences of social exclusion and isolation. And I think that we can't really underestimate both. You all talk from like both personal experience and, you know, frontline experience of what it looks like when people are unable to integrate, and what how much, you know, costly to the system that ends up being, as opposed to if we have the right systems and supports that are accessible. And it's interesting that you were talking about, Dr. Leis and Dr. Hanson, that your clinic has been evaluated and as culturally safe, right? When in the rest of the healthcare system, we are like struggling with either even have some like, you know, intercultural awareness and maybe competencies, but like we're really far from like being able to declare that we're practicing cultural safety.
Yeah, I hear you. Yeah, and I feel like you know, that was a very small study, first of all, and I think we just wanted to know, like, do our patients think that things are going well? Like, is this an appreciated service? So I hesitate to say, I mean, I think that the main message was positive from the studies, but I hesitate to say like, we're culturally safe, good job, because I feel like we should be a lot more humble than that. And I'm sure that not all patient encounters go as well as they should. We do our best, but obviously it's a lifelong commitment. And yeah. In terms of the Reach Clinic resources, Isaac.
Yes, there's questions here in the chat.
We do have dedicated mental health resources at Global Gathering Place. That, yeah, it's wonderful, but I think they're at capacity as well. But as far as OT and physio and social work, we don't. And the other barrier for a lot of our patients is, so for the first year after arrival, most of their access to like medicines, occupation, like OT, PT, home care is all under federal, not provincial jurisdiction. And so that causes a barrier. One, a lot of people don't know how to navigate that. Mm-hmm. The other thing that often happens is people will refuse to see our patients because of they're under IFH. Mm-hmm. And so physio, we haven't been able to access anyone in the city that will bill IFH or OT. When we refer someone to home care, which is provincial, then they'll say, oh, well, no, they're under interim federal health, so you have to go through this like private agency, which is often quite, it's a barrier. It's something we've been fighting against. And then the other thing, actually, unfortunately, so until you have a health, so as a refugee, when you first come, you're under interim federal health for physician visits as well, until you get a healthcare card, and then you transition to like provincially. So I've had more than once tried to refer patients to a clinic, and they'll say, no, we're not set up to bill interim federal health. And so they'll actually decline the referral. That has happened less and less, because I think we've made it known that you actually aren't allowed to do that. Like, under our code of ethics, you have to be able to provide care. And so that, I would say, has really tapered off. But initially, I remember it being quite an issue. Yeah.
Yeah, so we have been able to form some partnerships with, like, for example, a dentist who will see our patients, you know, same with eye exams. Doctor. Yeah.
Optometry.
And that's about it. Yeah, that's about it. What else was I going to say? Oh, yeah, the settlement workers are good at knowing which clinics, like in terms of urgent care and walk-in clinics, which is sometimes needed when it's after hours and stuff. Which ones are accept IFH and which ones don't. But yeah, and that shouldn't be a thing, but it is. Yeah.
There's another question here for Rosario and Adrian, but the walk was reach. It was reach walk, right? So maybe Karen and Jacelyn can update us too on how the fundraiser went and what are other ways that people can fundraise or contribute to the work you do.
The walk was it went really well. It was a little bit cold that day, so I think maybe, but no, it went really well. Lots of medical students were there, and they had a great silent auction. They did a very good job, so we really appreciated that. And one of our newcomer, he came as well, and he gave a speech, and he was actually a physician previously, or he still is a physician, but yeah, so it was a very nice, they did a really good job, and we really appreciate it. As far as how to kind of, I think advocacy and making it more, I would say,
just like community.
Yeah.
Or go ahead.
Yeah. Oh, I just wanted to thank you because you're really like all the points that you're saying. Like we told you, like the emergency act, like access decreases emergency care. We're trying to tell everybody that. So just like if we as students could like just get people to see and like, no, you actually can't deny people. Like it's unethical to deny people care. Like how do we shout this any louder? And I know it starts with people just knowing. And so integrating into the curriculum. So from medical students, we know, but also like we have to train doctors who are already trained in the community organizations that like, how to approach this, because like they just never had the conversation, or just like, you know, the interim federal health plan, it's like that's too much to look up and I don't get paid to look up, like to look that up. It's literally that barrier of like, I don't get paid to get trained about that. So okay, let's make it one of the medical competencies that you have to do throughout the year, that you do have to update yourself on, like knowledge about immigration policy. You know, just like one of the CMA competencies, like, okay, you don't get paid. That's literally the barrier for a lot of people, which I understand because I don't get paid either. but you know, like, I think that this is a start because you are the frontline workers and you're agreeing, like, this is what's happening. It needs to stop, but need to educate.
And I think, sorry. I was just going to say medical students, I think where you can really, just in day to day, when you're rotating through and you're in the hospital and you're with the resident and you're seeing somebody who, you know, doesn't speak English as your first language, you can say, oh, you know what, why don't we call translation services? I'll get it on my phone right now. And just kind of normalizing that is, you know, the standard of care and it's appropriate care. And it's really our ethical responsibility to provide that for patients. So I think the next generation will do better than us, and hopefully, and that's just,
Lisa, I don't know if you're still here, but maybe you could answer. No, she's not there. That's okay. I'm not sure about the donations to the community clinic. Yeah, I don't know, or do you know?
So there's a foundation.
Oh, there's a foundation.
Like a community clinic foundation. And so I can't speak to how exactly.
Canada helps, right? Something like that. We'll find it and maybe post it with the recording of these webinars, so you can also circulate it with your contacts.
And like Global Gathering Place, Open Door Society, those are great organizations. They do so much for us. They provide a lot of translation services out of their own funds, and so I mean, those are wonderful places as well.
I think if I remember right, we might have gone through Canada Helps. I think that sounds familiar. So I also just want to say, I know I sent in the chat, but I just wanted to say for the sake of the recording of the meeting that Rosie and I, while we appreciate the credit, we weren't the ones specifically responsible for this walk. One of our colleagues, Mohammed Armanazi, did a great job of organizing the entire thing. So I just wanted to make sure credit was given where credit's due.
Noted.
I'm also
Well,
just say goodbye. If I have to join another seminar.
I
But-
thank you all, and we will be in touch with you. Thank you for showing up, and we will stay in touch and keep having conversations and educating us and each other about health inequities in our communities. So thanks to the presenters and the amazing work that they do in the community and with other students. And yeah, we'll send you this recording and some links, and stay in touch. Stay tuned for the next webinars as well.